It's a scary thought for new parents. Your baby is born with a congenital heart condition. Some are significant and require surgery. Work taking place through OSF Innovation at Children's Hospital of Illinois is looking at new ways to bring new hope for the smallest patients.
We've done a really good job, we as in the congenital heart community, over the past 40 years of really improving their survival, where to the point where more than 90% of these kids are surviving. And now the next goal is to push that to 100%, but also to improve the quality of life for all these patients.
That's Dr. Harma Turbendian, congenital heart surgeon at OSF HealthCare Children's Hospital of Illinois. And I'm Shelley Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Approximately 40,000 babies each year in the United States are born with a significant congenital heart condition. About 1 in 4 of these babies has a critical congenital heart defect that requires immediate surgical or medical intervention within the first year of life. Dr. Harma Turbendian is a congenital heart surgeon at OSF Healthcare Children's Hospital of Illinois in Peoria and provides this critical care to our smallest patients. But he is also looking at new ways to improve and expand on the current standards through work with OSF Innovation. First of all, thank you for joining us. And before we talk about what you are working on, I want to take a step back. And first, why did you decide to become a pediatric congenital heart surgeon? What was your passion for this?
Well, I appreciate you guys having me. It's a very long time ago. I was back home in New York. I was a first-year med student between my first and second year of med school, and I was very close friends with a neonatologist and was doing some clinical research with him over the summer. And the congenital heart surgeon at the time walked through doing rounds, invited me to the OR, and I went, watched a case, and that was it. I was like, okay, that's what I'm doing.
That's what you're doing.
Yeah. It was just a combination of kind of all the things that took me to med school in terms of, the mental part of it, the physical part of it, the emotional part of it. It kind of came together all in one field, and I was like, all right, that's what I want to do.
So there are two things you are working on. The first, let's start with the novel partial heart transplant concept. Tell me what this is.
So partial heart transplantation is a relatively new field within congenital heart surgery that past few years has really come into vogue in terms of having valve replacements performed on patients using this technique, this idea. And so the idea we came up with was expanding partial heart transplantation beyond just the valves, where we're like, hey, why can't we use an entire chamber of the heart and see what happens? And that's where the idea started, was to apply the entire concept of partial heart transplantation to a chamber of the heart.
The fascinating thing in my head as I'm just listening to you explain this is when we talk about patients, we're not talking about adults like you and me. We are talking about babies, young kids. So are there particular patients that this is where you see the future in this surgery for?
Yeah. So the idea really came about using the concept to treat single ventricle patients. So there are kids who, in the media, they're born with half a heart. And so these are kids who within the 40, 45 years ago, a lot of these kids had a death sentence. And over the past several decades, congenital cardiac surgery and congenital cardiology has really advanced to the point where these kids are getting their surgeries. They usually have 2 to 3 surgeries at least during the course of their lifetime. And a lot of these kids are living to become young adults. But that being said, they still have some difficulties where their end game really is heart transplantation eventually. And the idea behind the partial heart transplantation that we're trying to develop is to use it to try to treat so-called failing Fontan patients. So these are kids who have undergone their series of surgeries and are at a point where their only other option really is to go on to whole heart transplantation. And so we're trying to figure out if this partial heart transplantation, what we call cavoatrial partial heart transplantation, is a way of either delaying or maybe even avoiding heart transplantation.
A little earlier this year, we had Dr. Joe Turek from Duke University on this very same podcast because he was in Peoria for the Geist Lectureship through Children's Hospital of Illinois. And he and his team at Duke back in 2022 did the first partial heart transplant in a newborn, critically ill newborn. How does the work you're doing either build on that or differ from that?
Yeah, so it's actually a really interesting story because the team at Duke, they, he told you guys and he told us during the Geist lecture, they did the first clinical application of partial heart transplantation with heart valves. The actual idea, it came from another congenital heart surgeon who currently works at Arkansas Children's Hospital, Tawfiq Conrad Rajab. So he came up with the whole idea for partial heart transplantation. It's a bit of a story, but kind of based on the observations that he saw with how hearts grow after whole heart transplantation. So he came up with this idea about the valvular part, and the team at Duke was able to identify a patient and able to forge ahead and apply his idea clinically for the first time. And so when I came up with this idea for cavoatrial partial heart transplantation, I actually know Conrad fairly well because we both trained out at Children's Hospital of Colorado. So I actually called him and I said, hey, what do you think about this? And he was like, oh, should totally run with the idea. And so so that's kind of the connection there where, I went back to Dr. Rajab and we talked about it. And I actually, right now, I actually collaborate directly with him on the project because he has an entire NIH-funded animal lab down at Arkansas Children's Hospital looking at partial heart transplantation. And so he's kind enough to collaborate with me and help with some of the animal studies.
So that's the other fascinating part. And I got this sense from Dr. Turek. Dr. Plunkett has been on, Dr. Mark Plunkett, who's with Children's Hospital of Illinois. When you talk about the United States is big, and there are selective congenital heart surgeons such as yourself. You're not a dime a dozen. It's very select, but you're also a very close-knit community who learns from, benefits from, and then expands on the work of the others. Is that something that is really beneficial to patients across the country?
I think collaboration in our field is a huge advantage. And like you said, going back to how you started out with this entire podcast, we're not dealing with the flu. We're not dealing with a common cold. It's not something that you see a lot of. So I think collectively as a community, both from clinical experience, but also from research experience, you have to take advantage of the collective experience rather than anybody's individual experience. Because when you have a greater denominator, whether it's dealing with patients, whether it's dealing with a research problem, more minds are definitely better than one or two working in isolation. And we have like you said, we have a unique small community where most people know each other. And in 2025, it's a matter of making a phone call, getting on a Zoom call and talking and trying to get things done.
And what does this ultimately mean? And what will this mean for patients in translation as this work moves forward? What is the goal?
The goal is to try to make our single ventricle patients' lives better. And so whether that's delaying a heart transplant, avoiding a heart transplant, kind of wait to see what happens. Obviously, this is research, so it might not work. So even if it doesn't work, the fact that, this is a collaborative effort where, like any other research, you're doing the work, publishing it, and even if it doesn't work but leads to a different idea that can help some other clinical scenario, then it's still a success.
Okay, let's talk about the other innovative project that you're working on, and I have to read this one because it is a mouthful too. Artificial cardiac muscles for the development of heart simulators. Tell me about that.
So this was another collaborative project that came up. So this is in conjunction with Matthew Bramlett, who's one of our cardiologists here, and obviously has a big role in JUMP, and also with an engineer down at University of Illinois, Sam Tawfik. He's actually a mechanical engineer. I'm pretty sure he's a mechanical engineer, and he has developed this technology of an artificial muscle, and it's actually a synthetic material that he noticed that he could get it to contract and expand like the muscles of our body do. So several years ago, the three of us got together on a phone call and we're thinking, hey, how can we apply your technology to the heart, right? Heart is a muscle.
Yeah.
And so over the past several years, we've been lucky enough to get some funding from JUMP to help with some projects, working with the University of Illinois, trying to see what we can do with this artificial muscle. So one idea was to use the artificial muscle to build an artificial heart. Now, whether that artificial heart is something that will go into clinical use to help patients who need mechanical support for their heart, or whether it's a heart simulator to do education on, device testing, things like that, yet to be seen. The other area where we're starting to explore is similar to the project with the cavoatrial partial heart transplant. Is there a way we can use this artificial muscle to help some of our congenital heart patients by providing them a support pump to help with the pumping function that they're lacking?
I imagine that's why that last part you talked about is specifically why this work is so important. When you look at the patients who may not have a ton of options, is that why this work is so important?
Yeah. Like within the field of medicine, this is all relatively new, right? These patients are just now starting to, within the past couple decades, are now starting to get to adulthood. And again, their only option really oftentimes is a heart transplant. And so can we figure out something different for these folks?
Yeah, because getting hearts to transplant is also a challenge. We all know that all organ transplantation is difficult. And so having that donor heart that works for a patient is a challenge.
Right.
So if you could come up with something else. Let's talk about does this set OSF Children's Hospital of Illinois apart? Oftentimes people will come, when you say this work is taking place based out of Peoria, Illinois, at Children's Hospital of Illinois and OSF HealthCare, people sometimes cock their heads sideways and go, Peoria, really? What do you say to people when you may hear that? Does this set Children's apart?
Yeah, I think it's a testament to the fact, we've got an institution here where you've got people who are committed to helping patients, whether they're the people of Central Illinois or the people in Chicago. It doesn't matter. When you have a group of people who are committed to what they want to do, they're going to have ideas to try to make things better. And yes, it's not a huge institution with lots of research funding, lots of facilities, but when you have an idea and you have the people who want to do the work, and then you have an institution who's willing to support those people to the best of their ability, then yeah, it'll happen in Peoria. And back to your point, with, congenital heart surgeons in general, I think it's the same thing. It should be the same thing with research, where in 2025, communicating with people, working with people is so much simpler, where even if you have the idea in Peoria, if you don't have everything you need in Peoria, then it's really easy to work with, people outside of Peoria to get your project done. And I've personally had that experience with flying down to Arkansas to do some of these animal studies with our collaborator down at University of Illinois. These people aren't in Peoria, but we're still, working under the umbrella of OSF and Children's Hospital of Illinois to get the work done.
And it helps the work because it is a destination center as we work to develop that even further. Okay, before we wrap up, I'm going to ask you to look into your crystal ball. These are great projects you're working on. They will take time. We all know that. This research does not happen overnight. You've already been working on it for a period of time. But as you look into your crystal ball, what would you like to see all of this lead to? What is the ultimate big win for you out of this?
Yeah, the ultimate big win is to really make our congenital heart patients' lives easier. We've done a really good job, we as in the congenital heart community, over the past 40 years of really improving their survival, where to the point where more than 90% of these kids are surviving. And now the next goal is to push that to 100%, but also to improve the quality of life for all these patients, because they have multiple surgeries, they're undergoing multiple procedures. And if this technology or another idea that comes about from this technology helps these patients, then that's really the big win.
Well, it's very fascinating. We'll look forward to doing follow-ups down the road and see how it progresses. Dr. Harma Turbendian, thank you for taking some time to share all of this great work with us.
Thank you. Appreciate your time.
And thank you for joining us as well. And remember, you can catch all episodes of OSF Healthcare Accelerated at osfhealthcare.org/accelerated.